Hello, good evening, everyone. So, welcome to our fourth Paul J. Galkin Global Health Grand Rounds lecture series of this year. My name is Ruhul Abid. I'm a faculty at Warren Alpert Medical School and also Rhode Island Hospital. And I am also a member of the Global Health Advisory Committee of the Center for Global Health Equity and the chair of the program committee, which actually organized these grand rounds. And so, about the this program committee, we have faculty members, student members who actually nominate and then select the guest speakers, and from there we go and invite the professors and bring them here. So the way we have been doing, this is our second year. So we started last year. We had 8 grand rounds, and this year this is our 4th. So the way we do it, arrange these grand rounds is one Brown faculty member and their counterpart at some international locations. They are doing global health work with them. So that joint collaboration, we want to encourage the collaboration and highlight their work. So one of our Brown faculty member speaks, and other is the international collaborator. And to organize this event, if I don't mention Megan's name, so that will not be good, because she is the main person actually who does most of the work, starting from help with the visa, invitation, accommodation, travel, everything, and including this great dinner you are having. So thank you, Megan. So, and then, yes. So, before, so as I mentioned that, so today's one is very unique in several aspects. So far we covered in grand rounds, this Paul J. Galkin grand rounds, we covered several topics: surgery, medicine, emergency medicine, pediatric health, women health, refugee health care, many different subjects. And ranging from the areas, like continents, from Asia to Africa, Latin America, and this is our first time we are going to cover the Oceania. So the Solomon Islands. So, and this, another way it's unique is because usually we initiate these collaborations by the faculty members. This is unique that this was initiated by one of your friends, a third-year medical student, Dylan Bush, who actually initiated this project prior to coming to medical school. So he's a third-year medical student now, but prior coming to medical school, he was a Fulbright research scholar in the Solomon Islands in 2022 to 2023, and he actually did initiate this diabetic amputation studies in the Solomon Islands, and he also advised their Ministry of Health and policy-making changes, including partnership with WHO and other organizations. So that's great. He will come later to introduce Dr. Stallone Kohia. But so without further ado, I'd just acknowledge our support, because without this support, we would not be able to conduct these grand rounds. So as you see from the name, that Paul J. Galkin Global Health Grand Rounds, so the Galkin Lecture was endowed by Mr. Arnold Galkin in honor of his son, Paul Galkin, who had died of a rapidly advancing malignancy. Mr. Galkin has been a generous patron of both the Miriam Hospital and Brown University in the past, who wanted to establish the lecture to honor his son, who had been a very accomplished young man, a patron of the local arts, and a pioneer in modern architectural design. So as you notice that today's title is H. pylori and gastrointestinal diseases in the Solomon Islands. So the topic will cover the global H. pylori gastrointestinal diseases and also the Solomon Islands. So our first speaker, Dr. Stephen Moss, who is a professor of medicine and the program director of the Gastroenterology Fellowship Training Program at Brown, and the director of endoscopy at the Providence VA Medical Center. Dr. Moss graduated from University College London Medical School. He completed a gastroenterology fellowship at the Royal Postgraduate Medical School in London and a second gastroenterology fellowship in New York, USA at St. Luke's Roosevelt Hospital. Dr. Moss's research has for many years focused on basic and clinical aspects of H. pylori infection, including the mechanisms of H. pylori-associated gastric carcinogenesis, and more recently, antimicrobial resistance testing. He has received awards and research funding from the American Gastroenterology Association, Fundenberg Gastric Cancer Award, and several NIH grants for his research. He is a co-author of the 2017 and also the 2024 US guidelines on H. pylori management, and is a member of the Maastricht group that develops international guidelines for H. pylori. He has over 200 peer-reviewed publications, served as a consultant at the WHO, has served also on the editorial boards of multiple gastroenterology journals, and was a counselor of the American Gastroenterology Association. He is a member of the Royal College of Physicians in the UK, an American Gastroenterology Association Fellow, and a Fellow of the American College of Gastroenterology. So, Dr. Moss, welcome, Dr. Moss. Thank you.
Well, thanks very much. It's a pleasure to be here. And we're going to talk a lot about H. pylori. And I'm going to start with a history lesson. So back in the 1980s was the first time where people developed flexible instruments to look inside the living human body, endoscopes. And this is a patient having an endoscopy, the way that we do it now, having some sedation. And then we began, when these instruments were available, it was clear that many people had ulcers in their stomach, and this is a picture of an ulcer that you might see at endoscopy. Now, back in those days, we had very primitive treatments. We knew that acid was important in the etiology of ulcers, and treatments were based on inhibiting acid, and they were by today's standards, very weak therapies. And many patients went on to have surgery to remove branches of the vagus nerve, which stimulated acid secretion. And some of them had half their stomachs removed because they kept getting ulcers. Now, the underlying cause of ulcers in those days was not known, but the main hypothesis was it was due to psychological stress. Now, the endoscope allowed not only to look at ulcers, but also take biopsies of the inside of organs, such as the stomach. And two Australians working in Perth, Western Australia, clinician and a pathologist, Warren and Marshall, for the first time found a bacteria living inside the stomach. And at the time when they found it, this was complete heresy because the pH of the stomach being 2, everyone knew that at that time that no bacteria could live inside the stomach. But going against the dogma, they managed to culture the bacteria. Their first abstract describing the work, which was sent to the Australian Gastroenterology Society, was rejected. So for those who've had abstracts rejected, don't worry. Good stuff could still happen, because 20 years later, they won the Nobel Prize in Medicine for their discovery that H. pylori was actually the underlying cause of ulcer disease. And these are the kind of studies which they did, and subsequently many others did, to show that these bacteria were in fact causing recurrent ulcers. So these were randomized studies in which people with ulcers either received acid inhibitory medicine and nothing else, or acid inhibitory medicine and antibiotics to eradicate their H. pylori. And you can see that if the infection was treated, the yellow bars, whether the patients had duodenal ulcers or gastric ulcers, the recurrence rate was markedly reduced, and subsequently people didn't have to go on to have surgery to remove part of their stomach. So we've learned a lot about H. pylori over the intervening 40 years, and we've learned that it's the most prevalent bacterial infection in the world. About 4 billion people on the planet are infected by H. pylori, and this map illustrates that in many parts of the world, over 50% of the population are living with H. pylori inside their stomach. So those really dark areas, the former Soviet Union, much of Central and South America, many places in Africa where we don't have a lot of data, and Southeast Asia, the kind of the hotspots for the most prevalent areas that have H. pylori. And even in the US, about 20% of the population have H. pylori, and most people don't have any clue that it's living inside their stomachs. This illustrates the natural history of H. pylori infection. It's an infection which is acquired in the first few years of life, normally by the age of 5. You've picked up H. pylori, or if you're fortunate, you haven't picked up H. pylori. And if you were to take a biopsy of someone with H. pylori, you would see lots of inflammatory cells inside the stomach, lymphocytes, neutrophils, so-called superficial gastritis. And then following that infection, most people go down the middle of that diagram. They still have gastritis, persists until they die of something else usually. It persists for 60, 70, 80 years, usually without any symptoms at all. Now, about 1 in 10 people who have H. pylori infection go down the left-hand side of the diagram and they develop an ulcer. A tiny proportion go down that less than 1% part and they develop a very rare malignancy of the stomach called a gastric lymphoma. And about 1/3 of people who have H. pylori infection go down the right-hand side of the diagram and they start to develop precancerous changes, the first of which is something called atrophic gastritis. They lose glands inside their stomach, and the small proportion eventually go on to develop gastric cancer. So gastric cancer is a kind of a rare outcome of H. pylori, but if you consider that 4 billion people on the planet have H. pylori, you can see that that is still a lot of cancers caused by H. pylori. And this is a process which takes decades, most of one's life, to go from H. pylori infection to cancer. Now, we don't really understand why people go down different pathways. Some of it is related to bacterial factors. H. pylori is extremely heterogeneous bacterium, as we'll see on the next slide or two. There is certainly an element of human variation. So people who have a more pro-inflammatory single nucleotide polymorphisms for certain inflammatory genes have a greater inflammatory response in the stomach, and those people are more likely to develop gastric cancer. And there are other cofactors such as salt intake. So H. pylori is an extremely heterogeneous organism. Unlike most bacteria, only about 70% of the genome is conserved across different strains around the world. And there are a number of different marker genes, usually virulence genes, that you can use to type H. pylori in different parts of the world. And if you do that, you can find similarities between different strains, and you can trace the evolution of H. pylori around the world, and it exactly mirrors the evolution of human beings moving around the world, emerging from East Africa and then spreading out from there. So H. pylori has been living inside our stomachs really ever since we were Homo sapiens, 200,000 years ago. One of the most important virulence factors of H. pylori is a cluster of genes on a so-called pathogenicity island called the CAG pathogenicity island. And what these cluster of genes do is they form a molecular syringe, so-called type 4 secretory system, which enables H. pylori to inject certain of its proteins and perhaps nucleic acids inside the host gastric epithelial cell and start the process of gastric cancer. So one of these proteins that it inserts is the so-called CAG-A protein, which functions as an oncoprotein. So moving from the more basic science to sort of more clinical aspects, how do we diagnose H. pylori? There's a whole variety of ways. It's a fairly easy organism to diagnose. If you're doing endoscopy to investigate people's stomach complaints, you can take biopsies, and one of the ways which we do it in the hospitals is to ask the pathologist to stain for H. pylori. You can see them under the microscope. Another thing you can do is called a rapid urease test, and I'm mentioning this because we'll talk about that more when we talk about the Solomon Islands. But H. pylori produces copious amounts of urease, which allow it to survive in the stomach because the urease generates carbon dioxide and ammonia, and it's the ammonia which allows H. pylori to neutralize stomach acids. But this urease activity can be pretty easily detected because it can change the pH of an indicator solution if you put urea in the indicator solution. So that's a H. pylori negative biopsy. If you put it in, it stays yellow, and if it has H. pylori in the biopsy, then it'll go pink after several hours. So that's a nice simple bedside test to look for H. pylori. Now, it's not necessary to do endoscopy to look for H. pylori. There are several non-endoscopic tests. There are breath tests. There are stool antigen tests, and many other tests. Now, I want to focus for the remaining part of the talk about H. pylori and gastric cancer. So gastric cancer is really common. It's the fifth most common cause of cancer death. And in most countries, it has a pretty dismal prognosis, about a 35% 5-year survival. So patients tend to present really late, and there's not a whole lot we can do. In some countries, they do endoscopy frequently, upper endoscopy, in the same way that we tend to do colonoscopy frequently, and they're able to detect gastric cancers at a much earlier stage. And places like Japan and Korea do that, and they have a much better survival, 70% or so. But it's been calculated that the vast majority of gastric cancers are directly caused by H. pylori, over 75% of them. So if we think about infection-associated cancers, you're probably familiar with HPV-associated cervical cancer, hepatitis B, and liver cancers, but actually H. pylori causes more cancers than both those, about almost a million cases per year of gastric cancer around the world. And H. pylori has been called a silent killer, so most people have no clue that they had H. pylori in their stomach, and most gastric cancer cases, by the time they're diagnosed, they have H. pylori, but they didn't know it. So gastric cancer is more important, more prevalent in some parts of the world than others. This slide illustrates that there is a spectrum there. The highest prevalence areas are in Eastern Asia, Eastern Europe, South America, basically places where there's a lot of H. pylori. And places North America is towards the bottom there. And the Solomon Islands, you may not be able to see, but that's about the fifth line there. That's kind of somewhere in the middle of gastric cancer prevalence. Gastric cancer is in a way theoretically preventable because there's a very long precancerous sequence which was described back in the 1970s before we knew anything about H. pylori. So a Colombian pathologist called Pylori Correa mapped the sequence of changes that occur in the stomach gradually over decades. And we now know that they're driven by H. pylori, at least in the early stages. So there is potential to intervene, to diagnose early, to get rid of H. pylori and maybe prevent cancer. Now, back in 1994, the WHO declared H. pylori to be a definite or class 1 carcinogen based on rather weak evidence at that time. But it really made it difficult to do the studies to prove that H. pylori caused cancer. Because, as you can imagine, what people really wanted to do is take people with H. pylori, give half of them antibiotics, half of them placebo, and follow them up. But once WHO declared H. pylori a definite carcinogen, of course, that was ethically rather a challenge. So we have limited studies, double-blind studies, to look if eradicating H. pylori from populations reduces cancer. And this summarizes these kind of underpowered studies, but from these several underpowered studies of small numbers, 30,000 approximately in each arm, which is a small for a cancer which takes decades to develop, the data is pretty clear that if you eradicate H. pylori from people, you lower their chances of going on to get gastric cancer by between 30 and 40%. And in the bottom half of the graph is some studies that have been done after patients have developed the gastric cancer, but it's been removed, normally endoscopically. If you then give them H. pylori eradication therapy, you can prevent them from getting a second gastric cancer sometime down the line. And again, the reduction is in the region of 40 to 50%. So one's enthusiasm for searching for H. pylori and getting rid of it really depends on the prevalence of H. pylori in the population and the prevalence of gastric cancer. So the numbers needed to treat to prevent one gastric cancer, and we're talking about treating with antibiotics to get rid of an infection, can be as little as 15 if we're talking about Chinese men, to as many as 200 to 300 if we're talking about US women. And so that kind of drives the thinking about whether public health in different countries see this as an important thing to do. Now, we don't have good studies from the United States about whether H. pylori eradication prevents gastric cancer. We don't have prospective studies, but we have a couple of studies that look like this. These are retrospective studies of large databases. This is the National VA database. And you can see that if patients had H. pylori confirmed eradicated, they had a greatly reduced chance of getting gastric cancer by 76%, compared with those patients in whom H. pylori was not eradicated when followed up for about 20 years. So this is observational and subject to all biases, but it's still quite a striking result. Patients with a family history of gastric cancer, very similar. Someone has a gastric cancer, you screen their relatives and offer them H. pylori eradication therapy. If they're H. pylori positive, again, you'll reduce the chances of getting gastric cancer by about 50%. And this was really an intriguing pilot study where they said, can we do mass population screening and treating? So this was a study that was done in these little Matsu Islands, which are close to China, but administratively run by Taiwan. And what this group of investigators did was they went to the islands, they offered them breath tests to see if they had H. pylori, and if they had H. pylori, offered them eradication therapy. And when they would do this over every 4 years for about 15 years, and they got to about 85% of the population of 10,000 people that lived in the Matsu Islands. And what they were able to show was that the prevalence of H. pylori went down dramatically, as you'd think, from about 65% to less than 20%. That was the easy thing. And then when they looked at gastric cancer incidence or mortality at the bottom, they went down also within 10 years. Gastric cancer incidence, 50% reduction, and mortality, 30% reduction. So you see the lines are really wobbly because we're talking about small numbers of cases, but impressive results nonetheless that you could screen a population and see a benefit within a decade. So should we be screening populations for H. pylori? The Matsu Islands experiment really shows that this is feasible and potentially has an important impact. And certain countries in the world have already started to put this in place. Japan, Korea, parts of China have already started screening their populations to find H. pylori positive cases, getting rid of the H. pylori, and then expect to see a reduction in gastric cancer. So trials of screening are underway in Taiwan, also in several countries in Europe, to see if a screening test will be helpful. So they've not yet had it as a public health measure, but they have trials of screening. And if you think about other cancers that we screen against, this is potentially a very good one because we have a long period of time when we could detect the H. pylori. Detection is pretty simple, treatment is pretty simple, and it's a common disease. And the WHO recently published this monograph looking at whether we should be screening in different populations in the world. And this is the bottom line on the right. So population-based H. pylori screen and treat programs should be considered a public health priority in areas or populations with elevated risk for gastric cancer prevention. Now, what about the US? So we don't get too excited about gastric cancer in the US because it's not in the top 10 of gastric cancers, but we should think about it, especially in minority populations. So the reference population at the bottom is non-Hispanic whites. So their reference population of 1, and you can see that almost every ethnic minority in the US has a much higher chance of getting gastric cancer. Korean Americans, for example, 14 times greater chance of getting gastric cancer. So maybe these are where we ought to be focusing our screening efforts. People have done some modeling studies. They're fairly old now, but they've shown that the kind of costs of a screening program appear quite favorable to screening programs that we're doing for other cancers. And so, focus screening, there's something called the Houston Consensus Conference, thought the focus screening may be better than screening everyone if we really want to prevent the most gastric cancers. And these are the kind of groups that maybe we should be thinking about screening for in the United States. And the American College of Gastroenterology guidelines are very similar, who thought that focused screening was appropriate for immigrants from high gastric cancer incidence regions and countries and all non-white racial and ethnic groups. So the United States Preventive Task Force, who basically look at all these things and then decide if this becomes policy in the United States, actually started to look at this back in 2022. They requested information from the public and from scientists, and then ultimately decided it was low priority, and they kind of dropped it for a while. But I'm hopeful that one day they'll get back to it when we have a properly functioning US PTF. So the last couple of slides, I just want to talk about the issues for clinicians globally, which is H. pylori eradication is not that simple. You need multiple antimicrobials with acid suppression medication given for 14 days. It's certainly more difficult than treating a respiratory tract infection or a urinary tract infection. We tend to be only successful about 75% of the case. There are numerous reasons why we're not that great at killing H. pylori. Some of it's related to these kind of complicated drug regimes, but the most important one is antimicrobial resistance. So like many other organisms, this is becoming a bigger and bigger challenge, and many of the antibiotics that we like to use against H. pylori is generating resistance to them. So you can see clarithromycin, levofloxacin, nitroimidazoles such as metronidazole. We're talking about greater than 15% resistance in many parts of the world. Amoxicillin, fortunately, not so much resistance. In the US, we've done a kind of lousy job of monitoring these. We don't track these systematically. But from a small number of publications published from a relatively small amount of states, but I'm glad to point out Rhode Island is one of them, you can see that the resistance is high in the US, about 30% and above for clarithromycin, levo, and metronidazole, much lower for tetracycline, amoxicillin, and rifabutin. So these tend to be the antibiotics we prefer in modern therapies. So now people are interested in antibiotic resistance for H. pylori. Methods are coming aboard to do this. I would say this looks pretty attractive to do stool molecular testing, so you don't have to re-endoscope the patient to get the H. pylori. You can look for it in stool with next-generation sequencing. And I think that's going to be the future of H. pylori treatment, is more focused treatment. So, just to summarize, I hope I've convinced you that H. pylori is an important global pathogen. Gastric cancer, which is a really common cancer in many parts of the world, is largely preventable. And this is really a public health issue and a global health issue, and people are now starting to think about whether we should be doing screening to prevent a common cancer. And the clinical challenge is antimicrobial resistance. So with that, I'll hand over to my friend to tell you about what's going on in the Solomon Islands.
Excellent. Thank you, Dr. Moss, for that really excellent talk. Something about the accent and the deep voice. I think you have to start a podcast. And the way that you pronounce the drug names, I think, is much more entertaining and smooth on the ears than we have here in the U.S. But my name is Dylan. I'm a third-year medical student, and it's really a pleasure to welcome you all to this talk. As Dr. Abid alluded to, it's historic in a number of ways. And I'm also really happy to see a number of people joining on the Zoom from Solomon Islands and Papua New Guinea. I think we can truly say this is a global health event. Before I introduce our next speaker, I'd also like to particularly thank Dr. Abid for supporting this event. Back when the program subcommittee started at the Center for Global Health Equity, I already began scheming, planning how to bring a Solomon Islander here to Brown. And I think maybe it was my persistence, some might say stubbornness, but ultimately Dr. Abid's support and endorsement that got this event here tonight. I also want to thank Dr. Abid for recognizing that this work, this connection between Brown University and Solomon Islands, tied together by medical students, including Ben Katz, who's here as well, is just as powerful as some of our larger collaborations with our faculty. It really goes to show how incredibly supportive the faculty is here at Brown of their students, and it's one of the reasons why I'm so proud to be a Brown medical student. I'd also like to thank so many collaborators who have contributed to this work. Dr. Moss, certainly, as well as Dr. Martinuke from Australia, and many, many, many Solomon Island surgeons, including registrars and consultants, particularly Dr. Jagili, Dr. Ciota, and Dr. Ware, as well as Dr. Melli. They have really been steadfast friends and supporters since day one, and it really does take a village. So part of the reason I feel that tonight's event is particularly important is that this is the first time that we're welcoming a Pacific Islander to the Global Health Grand Rounds lecture series. And here in the United States, when we think of the Pacific Islands, we might think of beautiful white sand beaches, tropical forests, beautiful flowers and plants, and all those things are true in Solomon Islands as well. But when we imagine the people of the Pacific, we think of mainly Polynesian people, like from the U.S. territories, American Samoa and Hawaii. People that have a certain food and culture. We might imagine people dancing the hula or having luau's. These things do not exist in Solomon Islands. And we might even begin to think and to begin to consider the fact that most Pacific Islanders are actually from Melanesia. People from countries like Solomon Islands, like Dr. Kohia, from Papua New Guinea. 75% of Pacific Islanders are from areas outside of Polynesia. And these cultures, these communities are not well studied or understood here in the United States. And if you've been to the Pacific, again, Ben, I'm looking at you, you know that every island has its own unique culture. You know that even every community within an island might have a different language, a different culture, a different custom. And if we are, as Americans and as global health researchers and practitioners, to meaningfully engage in the Pacific, we need to start to understand its people and its geography. So I hope that tonight's event sort of moves us at least one step in that direction. Now, to finally introduce our next speaker, I think I met Dr. Kohia in the resident call room of the National Referral Hospital of Solomon Islands. We had an immediate bond because he is one of the tallest people on service at the Solomon Islands healthcare system. And so finally he had someone who he could physically look up to, although I've been lucky enough to look up to him for a number of years in his work. And to tell his story is really to tell a story that is in some ways surprising and in some ways very typical of Solomon Islands. Dr. Kohia spent his early years on a small island off the southwestern coast of Malaita province, and his desire to pursue medicine and surgery was really informed by his upbringing and his experiences as a young child. Living in a community where the nearest hospital might be a trek, a boat ride, and a truck drive away, on dirt roads, no less, a young Dr. Kohia watched neighbors and family members suffer from chronic medical conditions for which they were unable to seek care. In fact, his interest in gastroenterology is in part inspired by witnessing some of his own family members, his father, suffer with chronic gastric disease. Dr. Kohia's interests and his steadfast hard work have led him into an incredible career. He has had several impressive accomplishments. Firstly, he won an Australia Award Scholarship to complete his Bachelor of Medicine and Surgery at the Fiji School of Medicine. And then he undertook surgical training, earning a Master's of Medicine with a focus in surgery at the University of Papua New Guinea. Dr. Kohia went on to win the top spot in his master's program, an accomplishment that has been recognized by the Royal Australasian College of Surgeons, and indeed no small feat given the fact that he was studying in another country and competing against students from all over the Pacific. During his studies, Dr. Kohia developed an interest in research, and he has co-authored papers on endoscopy, diabetic amputation, and surgical training. Dr. Kohia has presented this research to colleagues in Papua New Guinea and Solomon Islands, and he has won travel grants that enabled him to present this work in Fiji and in Thailand. He is the first Solomon Islander to undertake any sort of training in surgical oncology. He is currently at the Memorial Sloan Kettering Hospital in New York City, for which he won a prestigious Mamadi Sudavar Fellowship to attend. Dr. Kohia, aside from all of these other things, is also a consultant general surgeon in Solomon Islands, and he is the youngest consultant general surgeon in the country. To our knowledge, she's also actually the first ever Solomon Islander to deliver any kind of lecture at Brown. And I think, if I'm not mistaken, Dr. Abid, he's the first for the Global Health Grand Rounds lecture to be a surgeon. So, so I ask you that you join me in providing a warm welcome to Dr. Stallone Kohia.
Wow. Thank you, Dylan, for this really kind introduction, and thank you everyone for a warm welcome, and also for having me here at your prestigious institution, Brown University, for a grand talk. As mentioned, my name is Dr. Stallone Kohia, and I'm a general surgeon from the Solomon Islands. So my presentation today is titled, as you see on the board, Pylori and Gastrointestinal Disease from the Solomon Islands, Challenges and Lessons from a Low-Resource Setting. I won't dwell too much into the scientific aspect of H. pylori, as we had a wonderful presentation earlier by Dr. Marsh, but I'll be talking mostly in relation to the actual practice that we, as surgeons or physicians, back in Solomon Islands or an area of low-middle income country, face in managing such diseases. So I'll share a brief overview of our setting, the country of Solomon Islands, and then I'll talk a bit about the health system, our referral pathways, and then a few clinical cases that we've encountered. And also the collaborative study that I did with Dylan Bush and Dr. Mosh in H. pylori infection in Solomon Islands. And then I'll mention some of the lessons that we've learned along the way. So I'd like to start with presenting this particular case. So this case sort of really captured both the challenges and realities of surgical practice in our setting. So he's a male, 39-year-old, who presented to the endoscopy unit with features of gastric outlet obstruction. So he came in with vomiting, loss of weight, and also very cachectic. He resides in one of the villages in the far northwest of the country. So it's called the Treasure Province. So it's the one on the right, the end. He first sought care at a small rural clinic, and then, was as a referral pathway, those clinics are not well equipped with medical equipment and even drugs, or even very limited diagnostic capacity. So he was treated symptomatically and then get later referred to a sort of like a area health center. So these are typical pictures of like the villages or the rural setting in a country of Solomon Islands, in my country of Solomon Islands. So when I mention a village or a rural setting, it's not as you guys have it here in the States. It's quite different in terms of, as you can see, the houses are mostly made from traditional resources, and also some of them are not, it's a lack of electricity or access to, necessity of like running water and all sort of things that are really necessity for an actual quality of living. And so he was referred to a health center, and then because of, again, lack of diagnostic capacity, he was then referred to the NRH which is the only tertiary institution in the country. So we saw the patient on the 2nd of July, 2021. And as you can see from the images, these are the two endoscopic images that we've taken. And so the endoscopic image over here, as you can see from this side, left side on the screen, there's an ulcer. So you can note on the, it's around the pylorus, at the opening of the pyloric canal into the duodenum. So there's an ulcer noted over there with an area of erythema and also some swelling as well. So upon advancing the gastroscope and trying to get into the duodenum, there's also some difficulty in terms of advancing the scopes. So the patient already had some form of gastric outlet obstruction from the ulcer, and also there's a features of like a mass evolving around the ulcerative lesions. And so we took several biopsies for histology confirmation, and also, as mentioned from the earlier presentation, in our endoscopy unit, we only do rapid US testing. So we did a couple of biopsies to check for H. pylori infection. And as you can see from the slide, the patient got tested positive for H. pylori, so he was put on treatment for H. pylori infection. And then he was later asked to come back for a follow-up scope, usually done 4 to 6 weeks prior to the first procedure. So the patient came back, now complaining mostly of persistent vomiting. So his symptoms sort of worsened over a couple weeks. Ongoing persistent vomiting, which is mostly after feeds. And as you can see from the image, the one on the far right is a food debris over there within the stomach. So that's indicative of an ongoing persistent pyloric obstruction or gastric emptying. And on the other image on the left, it sort of showed that the ulcer sort of, much improved in terms of the healing because the patient was on treatment. However, there's still some difficulty when advancing the scope from getting into the pylorus to the duodenum. So it's like the lesion is, in terms of the mass is getting bigger as compared to the previous procedure. By then, the biopsy that we took from the previous procedure came back with a confirmation of adenocarcinoma or gastric cancer of the pylorus. We also managed to do some CT staging, which also revealed that there is already some lesions within the liver as well. So we are dealing with a locally already an advanced case. Because the patient was really cachectic, because of the vomiting and having a lot of issues with electrolyte imbalance, we've admitted the patient and also took the patient in for a palliative surgery, not a curative surgery. So this is what we did with the patient. So it's a procedure that is known as gastrointestinal. So as you can see from the schematic diagram over here, the tumor is left on its own, but we sort of create a bypass, So it's the stomach connected to a loop of the small intestine. So because the patient was quite sick for a very complex surgery, the patient might not make it. So we just do the sort of like a palliative bypass for sort of like an improvement in terms of bit of quality, in terms of feeding and all that. So now patient was then discharged, however came back again with persistent. The vomiting just worsened. So we initially thought that there's some issues with our anastomosis. So we take the patient again for endoscopy. And what we found was a stomach filled with almost 2 liters of bilious fluid. So that's the one on the right side that you can see. So reflecting an ongoing gastric outlet obstruction or an impaired gastric emptying. And also we did look through our anastomotic side. So this is an image of the small intestine, which is the jejunum. So it confirms that the obstruction was not a surgical anastomosis, however, it was because of his advanced, condition. Sort of like, put the patient down the line. So he sadly passed away a couple of days after this particular admission. Now I'll take you back to the context of my country, Solomon Islands. So it's a country made up of archipelago of islands, which is roughly 900 to 1,000 group of islands. So as you can see from the picture, those islands are, widely scattered with many rural villages that are, quite significant distance from the main center. And so this geographical dispersion sort of creates major barriers, particularly in access to healthcare in our country. The capital is located in Honiara, which is this particular island of Coral Canal. So you can see, which is sort of like the big island in our country. That's where the capital is, and that's where the only tertiary hospital is situated, and also the only endoscopic unit. To give a bit of context in terms of the region location of our country, so it's a 3-hour flight from Australia, as you can see, and Papua New Guinea is far towards the northeast. That's where I went for my surgical training, and this is Fiji, where I went for my medical school. Now, a bit of history in relation to my country, and also of particular importance with United States of America. As you all know, the history of Solomon Islands span back to the World War II, and the island of Guadalcanal, which is where the capital is located, perhaps play a very, very big important role in the World War II battle. So in 1942, the Battle of Guadalcanal is sort of like a pivotal point where the Allied forces, the Marines, stopped the advancing Japanese forces from, advancing through the Pacific Islands. So this make a turning point in this significant war. So as you can see, this is also another picture of the Allied forces landing on the shore of Guadalcanal. So this history underscores the significance of the islands, but also reflects these rugged terrains and challenging terrains, which is continue to influence our daily life and also the access to healthcare for our population. So my country is, as according to the WHO data, 2023, it's a population of 800,000. So as mentioned by Dylan briefly, it's made up of, majority of the population is made up of these three ethnic group, which is known as the Melanesian group, and the Polynesians, and these are the Micronesians. But then we also have minority groups as well. And as you can see from this other pie chart over here, this is of great importance because mostly around 70 to 80% of the population lives in the rural areas as compared to urban sites. So as mentioned earlier, our rural area is not as, what is known as the rural areas in the United States or in the first world countries. When we talk about rural areas, it's those areas that are, have very, very limited access to, proper water sanitations, electricity, and also healthcare. So apart from the scattered islands and all that, the majority of population also live in those particular remote areas. So this is a very, very big challenge for our health system. Now moving on to our health referral pathways. So we do have a chain of referral health centers that patients do typically follow when they do want to seek a health medical officer or treatment. So typically at their rural setting, they will go initially to a nest aid post, and then they get referred up the system right up to the National Referral Hospital, which is the main tertiary institution in the country. But bear in mind, along those processes, it's also areas of delays are very common because those patients need financial assistance. They will be able to travel from one center to another center, and the traveling is usually by boat and also by trucks and all that. So it's quite expensive in terms of the finances. So apart from the geographical disparity and the rugged terrains, this system also pose a very, very big impact in terms of how patients get delayed in getting ultimate treatment. And as you can see from these numbers over here, there's a lot of medical officers and health officers in the main hospital, but as you go down to the community, numbers become smaller. So, in areas where there is 70% of the population there is not much health officers, or even worse than that, the health centers or even the clinics are not really resourced properly. So there's a very, very big disparity within the numbers and the access to healthcare. So these are pictures of those typical facilities out there. So this is the National Referral Hospital, which is located in the capital. This is Gizo Hospital in one of our provinces in the western part of Solomons. And you can see as you go down to the rural setting, it looks a bit more different, and also in terms of the resources. Now, I just want to, to talk about a little bit of experience that I had when I was a very young surgical registrar, or surgical residence, you will say it here. I was posted to one of the Adventist hospital in the region of Malaita province. That's also the province that I am from. This particular hospital, like you can see from this picture, is located at the base of the mountainous Koyo region in the province of Malaita. Now, this particular hospital serves a catchment of roughly close to 100,000 population, because this province is the highly populated province in my country. And so in this particular hospital, they only have one doctor. So the doctor, during that time, the doctor was away, so I was called to, sort of like cover that particular time. So as you can see, the access to, from this hospital to Honiara, which is in Guadalcanal, which is the capital, is either by air, or you can also go by boats, such as this one here. And one thing about this particular location hospital as well is that this community around here are prone for, tribal fighting, so it's also poses a challenge or even limits the options of healthcare professional wanting to go and work in this particular hospital. So it's also another issue on its own that also affects how doctors wanted to go out and work on those particular hospitals or even the clinics. So I was there in that particular hospital, and we have a case that came all the way from one part of the island. So they use banana boats such as this, to travel. Sometimes they get fluids in the boat. So this is depicted in this picture. So the patient came in. He's a 45-year-old male, present with acute abdomen. So clinically, when we assess the patient, bear in mind we don't have, well equipments in that particular hospital. There is no anesthetic officer as well. But on the clinical examination, it's a typical acute abdomen suspected with the perforated appendix. So we do the surgery right there on the hospital with the assistant from very senior nurses who help out for us to do the operation under spinal anesthesia with some sedation. So this experience or this particular story reflects how timely intervention at this kind of level, can save lives or even prevent patients from undergoing those long pathways, like the referral pathway chains, or go through those, boat rides and all that. So it saves time and even can also save lives as well. Now, coming to the National Referral Hospital, that's where I'm currently practicing. At the moment, we have only 4 general surgeons. And from this graph, as you can see, the blue line sort of noted that we only have 6 surgeons in the whole country. Okay. In the National Referral Hospital, we only have 4. And for me, being away, now we only have 3 surgeons. The number for the past decade, it's sort of like plateau around that level. Even though we try and send as much as doctors to do general surgery or other specialty, we also lose doctors along the way as well. So in the National Referral Hospital, we only have 4 anesthetics, 3 operating theater rooms, which we share with other specialty like orthopedics, OB-GYN, and no ICU in the hospital. And then we have our surgical ward is just a 48-bed general surgical ward. I think Ben Katz and Dylan are familiar with this picture. And we see all types of cases from trauma to acute abdomen, all spectrum of cases that comes through the emergency department. And so in this kind of setting, even though there's limited resources, as a very young doctor practicing, you tend to do a lot more, and also expected to do things that is beyond your sort of like your job description. And that's what we sort of it's not that we emphasize, but sort of like the environment sort of push us from earlier in our career to really do beyond our means, to support our health system in that manner. And this is our half of our team, as you can see from the picture over there. So we have 2 of our general surgeons and mostly the registrars and the residents. Now, the endoscopy unit just started recently, our endoscopy unit. So it was started way back in 2011. And it was started by Dr. Eileen Natuzi. This is the lady here, and she's from United States of America as well. So she had a close ties with Solomon Islands because I think one of the relative was Allied Marines during the World War II. So she sort of, have that attachment with Solomon Islands. So it initiated the endoscopic unit back at that time, and then 2014, the Australian New Zealand Gastroenterology Association sort of took over the job, and they started the intensive training for us. So they usually come twice a year to do intensive training in endoscopy. And our endoscopy unit was set up in 2019, so it's quite recent. Now, the study that I've done with Dr. Moss and Dylan, basically, so it's way back, as Dylan mentioned, 2022. I was a surgical registrar at that time, doing some part of my time in the endoscopy unit. And so I was looking for sort of like a thesis program for my master's degree. So it's like it's a requirement that you have to have a research. So I was looking around, and because I was in the endoscopy unit as well, and we don't have actual data that is like available in the country. And I would say for the region as well, there's no data in Fiji. Actually, there's a data that is like outdated. In the neighboring countries, there's not much data on endoscopy. So I was looking, because I was part of the endoscopy team. And so I met Dylan, and I was so surprised that he speaks quite fluent Solomon Island Pidgin. So we have a mixture of, because we have different dialects, our regions, but we do speak what is called Pidgin, which is mostly English and some mixture of dialects, local dialects inside. So that's like a common language that we use. And Dylan speaks quite fluent Pidgin. So I was so surprised when I met him. And then he later told me that he spent a couple of months in the western part of the Solomon Islands as a research patient. So that's where we get connected, and I asked him to, sort of help me out with my thesis program, and sort of like a mentor, and also been part of the journey, and also the very reason why I'm here today, because it started from that particular discussion in that residence room way back in 2022. So, this sort of collaboration, even though it's just for me, it's just for the MA thesis, but then after my program, the collaboration still goes on, and now I've built a lot of networks, not in New York, but also here in Brown University as well. So this is an overview of our study. So it is recently published around middle of this year. So you can see we collaborated with Dr. Moss as well. So our study is a 4-year retrospective study. We've looked at 761 patients. But bear in mind, these are symptomatic patients. So it doesn't really reflect the general population, because these are patients that actually have symptoms and they come to the endoscopic unit. And this is where we got our data from. So it's not reflective of the general population of our country. And so this is the summary of our findings. Surprisingly, in the population that we've screened, the prevalence of H. pylori was roughly around 26%. So we sort of like expect a bit more higher, because from literature and all that, we expect a bit more higher in terms of in terms of the numbers. But this is all our findings from the study. And H. pylori, statistically significant association with all this are confirmation of literature as well. And then from this particular study, 29% of them failed the H. pylori initial treatment. So already some form of antibiotic resistance existed in this particular community. And also we find 5% of them had GIT cancers of all sorts. So these findings really highlight that the burden of upper GI disease in our setting, and a need for clear, ongoing surveillance, education, and early diagnostic access, and improve treatment options for our patients. And the reality of practice in a country such as Solomon Islands or any other low-middle income countries is the fact that you tend to do multiple roles at the same time. So being a general surgeon, you can also be an endoscopist on another time, and then on the next day you can be in theater doing cases. And sometimes you can be, do a little bit of role in terms of oncology as well. So it's not only common for Solomon Islands, but other lower middle income countries in the Pacific, you tend to, have multiple roles in terms of how you look after patients. Now I'll go through another 2 case presentation, and then we'll look at up some other challenges, and then we wrap up from there. So the next case is a male, 51 years old, which we saw in the endoscopy unit around May of 2020. The complaint was just dyspepsia, so it's complaining of abdominal discomfort. And then we did a gastroscopy during that time, and then we noted there's an ulcer, as you can see from here. That's the incisor of the stomach, and this is the pyloric canal and the pyloric opening over here. And then beyond that is the first part of the duodenum. So when we did the scope, we've noted that there's an ulcer there, and then we collected biopsies for, histology and also H. pylori. And then he tested positive for H. pylori. We put him on treatment, and we asked the patient to come up for a follow-up scope 6 weeks after. He did not turn up. He came back a year later. So around 9th of July 2021, a year later from the first presentation. Now the problem worsened. Now he's having postprandial vomiting. So after feeding, a couple of hours, then he vomits. And then when we did a scope, the ulcer progressed, larger than before. Already there's some areas of erythema, swelling that is noted on the scope. And this is common in areas like in Solomon Islands, where our biopsy results sometimes the results are not available. So we do histology in country, but most of our specimens we send to Brisbane, Australia. So it takes a couple of weeks for the results to come back. So for this particular case, the result from the previous endoscopy procedure wasn't available. And as you can see, he was tested positive earlier, and now he still tested positive for H. pylori infection. So we put him on the second line of triple therapy. So we have, in terms of our antibiotic guidelines, we have a first line of treatment that we give for H. pylori infected patients, and if it's still positive, we move on to the second line of treatment. So this is what happened to this particular patient. And then we asked him to come back again to review the results. And then he came back like end of the year. So sort of like it's lost to follow up. Now came back, the symptoms persisted. So you can see from the scope images, the ulcer just, multiple areas of swelling around the area. Now it's involving the lesser curvature of the stomach. Where initially it was only on the incisor of the stomach. So the disease progressed dramatically over the past couple of, a year or two. And then the histology result, again, came back. Now it was positive for adenocarcinoma. The clot test now it was negative. So we asked the patient to, we scheduled the patient for surgery, but then he did not turn up. Now he came back in 2022, full-on gastric outlet obstructive features, cannot take in anything, loss of weight. And by then our histology result was confirmed cancer. So we asked the patient for him if it's okay to proceed for surgery. So for this particular case, we did a bypass, not a bypass, but a resection of the side of the tumor. And you can see from this diagram, anastomosis between the remaining part of the stomach and the duodenum. And he lived for 2 years and just recently passed away around the middle of this year. Now, the lesson from this gastric cancer case is similar like the one in the beginning of the talk. I think it's very obvious that, timely follow-up is critical, but it's not usually the case in my part of the world. Our histologic pathology results usually, delays pretty long. Sometimes it takes 2 weeks if you're lucky, but it can take 4 weeks. And sometimes, like this particular case, the results the specimens just get lost along the process of the logistics and all that. Of course, there's other challenges like, patient-related barriers. We don't know why the patient did not turn up those times. So it might be some financial constraints, because living in the city, if you stay with a relative, it's quite expensive. So these are some of the challenges that patients go through by themselves. And also maybe some other beliefs, which is quite common in my country as well. And so these are some of the lessons that we can look at in terms of this particular case as compared to the first case as well. Now, there's another case, a female 60, again, get referred from one of those villages from the rural part of the Solomon Islands. Came in with progressive loss of weight and dysphagia, so cannot swallow food or solids, and only liquid. So these are the two images from the endoscope. As you can see, there's a very big lesion, almost circumference around the oesophagus, and it's spanned from the mid-oesophagus right down to the distal end. And so we did a scope, and then we saw this area, and then we managed to do a bit of dilation. So I think Dr. Moss knows, we put through an instrument that sort of like dilated a bit the lumen so that, patient can take in a little bit. And we asked the patient we booked the patient for another follow-up procedure to put in a stent. She was also tested positive for H. pylori. So apart from this, he was also treated for H. pylori infection as well. There's nothing in the stomach, actually, no lesion or nothing, just the one in the oesophagus. So we did a follow-up procedure on him, managed to put in a stent, so just a palliative, just to dilate the stomach a bit, the oesophagus a bit. And also we took biopsies as well for this particular patient. And then this is the follow-up endoscopic procedure. And as you can see, this is the previous stent, and when we did subsequent follow-up, the tumor sort of extend beyond the stent into the stomach, so we took out this particular stent and put in a bit longer stent so that just to give her some relief, dilatation. And then the histology also confirms squamous cell carcinoma of the esophagus. So already on advanced stage. And so the patient passed away this couple of months from this particular procedure. So for this particular case, what I want to highlight is, even though we are limited in a lot of our how we do our treat our patients, we tend to do procedures such as stenting, even though in a limited setting, we tend to do such procedures, which really reflects that if we, it's a proper training or advanced, training for the staff, we can do some interventions such as this in our setting. So it's not difficult to do such procedures, but it's just need proper training or right mode of training for the health officers or the doctors. So now there's challenges in practicing surgery in a low resource setting. So these are, you can add a lot to the list actually from my presentation, but these are some of the challenges that we really face. I put them in a system-related challenge, which is related to the healthcare system. And there are some things that you cannot change because it depends on policies from the Ministry of Health and the government of the day. But then also there's some challenges that are related to the patient as well, how they believe and all that, which affect their health-seeking behavior. So these are multiple challenges that we, as doctors practicing in that particular setting, we sort of face every day in trying managing these kind of patients. And apart from these challenges, we have, opportunities and areas of improvement as well. So, we're looking at areas to train and upskill our local clinicians, not only in endoscopy, but also on other means of specialty as well. I think one thing that I want to emphasize here is, apart from all these opportunities to improve, I think the develop a telemedicine, a regional referral network is quite important. I think especially for us that we can, communicate with specialist people like Dr. Mosh, who is here in the United States, but you can send him, images and stuff like that, which we can collaborate on that particular network in try to manage difficult cases. So we do that a lot with our patients, and we collaborate with doctors in Australia and New Zealand who are close to us. But these are some of the ways that really help us in practicing our managing our patients in our setting. And of course, as I was alluding to earlier on with the students today, I think public health, in terms of awareness and education is a very big thing. I mean, in an area that we don't have, diagnostic modalities or treatment option, it's good to come back to the basic, to come in front and try and educate the patients, try to prevent, all the cause of everything. Because when the patient, have advanced cases, it's quite difficult to manage. So it's public health or primary health. It's very important in terms of managing cases in our country, not for GI disease, but diabetes, that we have a paper on diabetic amputations, which again comes back to this area of primary healthcare, which needs to be more focused on. And apart from that, international collaboration is very important. I think for me as a patient, I've collaborated with a lot of, example, Dylan, Ben, and Dr. Mosh, and also some colleagues in MSK. And these are things that really help us, doctors in the low middle income countries, to really progress and do our part of our job. So such partnership, enhance our surgical practice, So these are some of the things that we've initiated from our endoscopy. So like Dr. Eileen Natuzzi in 2012 started the endoscopy, and then the other group sort of carried on. And the collaboration between Brown University, as you can see, Dr. Moss and myself and Dylan, we did a GIT paper, diabetic studies, and also Dr. Koh, who was here earlier, also worked on penile paraphenoma in the Solomon Islands. So these collaboration partnerships are very important for us who practice medicine in such environment. This is Ben doing the research workshop. The one earlier was Dylan there, right there. Yeah. So I think that's it. To wrap up, as the conclusion stated, our country is really scattered, as you can see from our mapping earlier on, with limited infrastructure. So it's posed a very challenging, unique challenge for us. Our healthcare relies on rapid clinical decision and responses, and also efficient referral pathways. Those pathways are there, but it's not really efficient. Limited resources in the rural areas. I'll come back to the pie chart earlier where 70% of our population live in the rural areas, so it's really difficult to manage such. And of course, local studies, collaboration, those are very important for us to get the numbers, and can also change policies as well. And I think I've talked about this earlier to the students, like practicing an area that is, such as ours in a low middle income country. I think you have to come back to the basis of your medical training, medical school training, where your history taking is very important. You have to, know your history taking pretty well, and your clinical examination. You cannot really go beyond that. Because, practicing an area such as ours, where we don't have the best diagnostic modalities, no technological equipments to help us, we rely mostly on our history taking and our clinical examination skills. So this is a very basic thing that we learned in our medical school. I think it still stands true for us who practice in areas where there's limited resources. We rely mostly on our clinical skills and history taking. I think that is for the students to take home. Thank you very much, everyone. So this is my acknowledgement. I know my colleagues from Solomon Islands are on Zoom, so I want to acknowledge them, the surgical team and endoscopy team as well. Of course, the Ministry of Health and Medical Service, the Ansgita team who initiated the endoscopy program, and our collaboration here, Dr. Moss, Rahul, Dylan Bush, Ben Katz, and also all the faculty members and students. And thank you all for listening.
That's great. Thank you very much. So I would like to invite the speakers to come and have your seats here. So we have a question and answer session. So we can bring it forward. Yep. So if you have any questions or comments for our speakers, please go ahead. But I would like to start first while they're thinking. So one question to Dr. Kohia is, so what is the major professions of your, majority of the populations, like major professions? Yeah. Like agriculture or fishing or...
So mostly because majority of the population lives in the rural areas, so mostly subsistence farmers, So depending on which area, so some they live along the coast, some they live inland. So those along the coast they tend to do more fishing and all that, and those inland more of farming. So, but pretty much it can interchange with all that. But a lot of subsistence farming is quite common.
Thank you. And Dr. Moss, I have one question for you. So, because it reminds me of my medical school days, it was before H. pylori was recognized as or given Nobel Prize. So I did my medical school and internship in Dhaka Medical College in Bangladesh, which was the largest hospital there. That time it was 2,000 bed, now maybe it's 3,000 bed or something. So we used to do clinical rotations as a student and then internship. So the major surgery was gastrointestinal. If one ward had 10 surgery booked, 6 would be for gastrointestinal. So that reminded me that old days, as I mentioned. So my question is what is the most reliable non-endoscopic test? Like you can do it for large scale screening. Which one you do?
There's two very good, reliable tests, and one is the stool antigen test. You do it on a stool sample, and the other one's the urea breath test. So the patient takes some labeled urea, and if they have urease activity in the stomach because they have H. pylori, you can detect it in the breath. And as you can imagine, most patients like to do the breath test over the stool test.
Yeah.
But they're both very good.
And that will be more efficient for screening in the community, I think.
Yes.
Yeah.
Yep.
Thank you. Yes.
Outstanding lectures. Thank you so much for being here. I have a question for Dr. Kohia. I see the challenges that you're facing, and they're immense, and yet you do so well for your patients because of your dedication to the craft and also your team. How many hours a week do you work because of this type of situation? Because I see the dedication, I see the challenges, and this must be pretty hard for your lifestyle back home.
Yeah, so I practice mostly in the tertiary center, National Referral Hospital, which is the only tertiary center in the country. So at the moment, because we are only 4 surgeons, so we rotate 1 in 4, and it's pretty much just on call, you're looking after your own team. So even when you're not on call, but you also have your own teams that look after your own patients. So we pretty much just walk. Yeah, a lot more. But that's why I was earlier mentioning that our younger doctors, we sort of put them to really do a lot as well, so that so it's sort of sometimes we are a bit relaxed, but it's mostly throughout the week we do cases. And we see a lot from traumatic brain injury, acute abdomen, and all sorts of cases that comes through. And like I've mentioned from a couple of cases, most times they do come pretty late as well. They stay out there in the islands. So it's quite common to have them in a very late presentation.
Yes.
Thank you so much for speaking with us. I had a question. When you said that around 30% of the treatment for H. pylori was unsuccessful, you said that this was indicative of antibiotic resistance already in the population. Is there another factor that might have been impacting that success rate, or is it definitely antibiotic resistance?
Well, so it's not like we just, the particular percentage is for those patients that are on our first line, and then when they come back, we check and they still have positive outcomes. Okay, you can put that like it's an antibiotic resistant, but there's one thing about our population as well in terms of treatment. The course of the treatment for H. pylori is it's not only one drug, it's like a couple of drugs where you take for number of certain times a day. So sometimes non-compliance is a very big thing for our group of population. So we also suspected maybe they are not really taking their treatment quite well as yeah. So it might be non-compliance as well. But one thing about treating H. pylori in our setting, we tend to give out there in those health centers the first line, even though we don't have a confirmation that patient have H. pylori infection. So if anyone with, this dyspepsia and all that, we tend to start them on those treatments. So there is no well-set guidelines we follow. So sometimes maybe they have already on that first line of treatment when we see the patient. So that's why maybe they are not compliant or get resistance. Those are some of the likely reasons why we get the percentage number. Yeah.
There was a question from someone here.
Is there any, or I know both of you spoke a little bit about screening for H. pylori to prevent development into the gastric cancers. I'm a pediatrician and I think a lot about prevention, and is there any data or knowledge about how early one needs to screen to be able to prevent the development towards cancer? I know not everyone develops cancer, but I was curious.
Yeah. So this is a disease which starts in infancy, we think, an infection which starts in infancy. It's interesting, the pediatric guidelines are different from the adult guidelines. And they're actually not advocating screening because they think that in kids sometimes they can get infected and naturally get rid of it. And so there is an intellectual argument that the H. pylori may be beneficial in terms of developing immune responses. It's like the hygiene hypothesis in the stomach. And so the consensus seems to be that young adulthood is about the optimal time. Once you've developed your immune system, you've established whether or not you're H. pylori positive or negative, that would be the time to screen. Maybe 25, 30 years old, something like that. Practically speaking, people are looking also at middle age because that's the time we screen for many other cancers. And so if you're doing stool-based testing for colorectal cancer screening, for example, you can use the same specimen and screen for H. pylori. So modeling studies suggest the earlier you screen, the better as young adults, but practically middle-aged people may be the people who are going to get screening.
Yes.
Well, thank you both so much for coming here and presenting to us today. My question is, so you were speaking to some of the challenges, both on the systems-based side and the community side to providing the best, to achieving the best outcomes for your patients. I was wondering, are there any areas that you've identified that like the broader global health community can best help you in your mission to improving?
Yeah, so I think apart from the numbers, like 70% of our population live in a rural area. Also, the literacy rate is also sort of like similar to, it's quite very low out in the rural areas as well. So I think for us, the focus will be more on awareness and educating those patients, because even for basic education training, it's lacking in the rural areas. So most of our population out there don't have some form of education. So understanding, such even to come to the hospital, it's a very big thing for them. Like they have their own beliefs, and those are things that we try to intervene and try to break off those beliefs. So apart from those things, I think educating our population is one of the key areas. I think not only for GI cases, but also other cases that are of rise in our country as well.
Yes.
Thank you all for coming to speak about this. I had a question about the what you think would, I guess, research would look like, or how it's going to go forward, given that there's a lot of variance for the H. pylori strains across the road, and the fact that the WHO has defined it as a carcinogen. How do you think research to explore it will look like moving forward in order to, and also given the fact that there's lots of antibiotic resistance?
Yeah, so I think that the important research which has already started are the trials of screening. So just because a screening program sounds like it should work, it doesn't mean it will work. And you have to think about the downsides of over-treating and antimicrobial resistance. So in the next 10 years or so, we should have the results of trials where some people were put in a screening program, other people are not in a screening program, and looking at outcomes. We won't get a good idea about antimicrobial resistance in the general population, but we will at least know if screening will prevent gastric cancer in reality, the way that it's supposed to in practice. We could be in a situation like we are in prostate cancer, right? So we used to screen for prostate cancer. Obviously, people thought it was a no-brainer. You screen, you find a high PSA, and you treat, and you prevent advanced prostate cancer. But in reality, it was not successful because we were finding a lot of things that were not maybe so clinically important. And now there's move against screening, and now people are looking again at rescreening for prostate cancer. I actually have an expert in the room here. But just because something sounds like it should be amenable to a screening program, it doesn't mean it is. So we have to do those trials.
Yes.
You said that there are a lot of doctors leaving the Solomon Islands who are training there. I feel like we even hear in Providence about not being able to retain healthcare workers, and it's a worldwide problem. But how are you and your colleagues trying to help practitioners remain in the Solomon Islands who are training there?
Well, that's a very big challenge for us. Obviously, I think in the Pacific, we as compared to our neighboring countries, we are the lowest paid medical officers, like that's for Solomon Islands. And we have a lot of offers from other neighboring countries which they need, specialties like in surgery and all that. So a couple of doctors are, leaving. But I think to really try and stop that from happening, it's quite difficult. And it really comes down to, I think, the individual choices and all that. There is no ties with the government, like in terms of bond or whatever, at the moment for us. So when you finish medical school, you get your license, doctors can leave if they want to. There's nothing really holding us back from that. But the fact that some of us remain over these years, it's basically because pretty much of the passion to stay and help our country rather than looking at the money side of things. Yeah. So it's really comes down to the individual rather than and it's we don't have at the moment ways to prevent brain drain in our country in terms of our local doctors. Yeah.
So I have a question as a kind of follow up to that. So your hospital is a government hospital, right, Dr.
Yes.
Kohia, and all the doctors are paid by the government. So the treatment is also free,
Yes.
So medicines and everything is free. Yeah.
So our system is a public system where everything is free, and then there's a couple of advantages from that, but the disadvantage is the way that patients they tend to rely more on those things that are free and rather than really, so it's affect the health-seeking behaviors of our patients as well. And apart from that, the referral pathways, the government sort of give money to send patients from one area to the next. So they tend to wait for the money, and some delays can happen along the way as well. We don't have a hospital that is private. We only have one hospital, and it's a public health system.
There is no private practice system.
We don't have a private practice hospital, only smaller clinics, but nothing. And there's no other hospital that is private there.
Thank you. Yes.
Just to follow up on your question here, I'm sorry, but it was a good question about what can you do locally to help out on a more global equity, and the challenges that you talk about is incredible. And interestingly, just last weekend I spent a weekend at my 35th medical school reunion. Yes, I am that old. And I spent it with a colleague of mine by the name of Massey Beveridge. And this is a guy who's a general surgeon, trained in Toronto and another Commonwealth. So he trained in Toronto and he did reconstructive and trauma throughout the world, Africa, Afghanistan, Cambodia, International Red Cross. And he set up the International Office of Surgery at University of Toronto. And he described 4 things to us during our reunion. We keep asking him, Massey, you're the most interesting man that we know, like Dosaki beer, right? He's the most interesting man in the world. And the challenges he described were scarcity of resource, which is exactly what you talked about, which is outstandingly important in order to deliver the quality of care. Number two is moral triage, deciding who to operate on and when not everyone can be saved because of the scarcity of triage. Extreme personal risk, because in some areas that you go to outside of the United States and North America, you're actually faced with significant civil instability in different parts of the world that we're not personally so easily deal with, like in Providence and other centers locally. And the last thing is what you also talked about earlier, which has to really be emphasized, which is the emotional burden of constant exposure to systemic inequity, since the title here is global health equity and human suffering as a result of that because of lack of resource, lack of people. How do you triage the care? So these are the four things that I learned the past weekend. And do you think that's kind of where things
It's pretty
are
much,
as well?
actually, what's like I mentioned about the operating theaters earlier on the slide. We only have 3 rooms, and the OB-GYN takes preceding if there's a cesarean section. So we always fight for the space, Sometimes we book cases that needs to be done in that particular day, but if there's a lot of C-section on the list, you get pushed out, eventually scheduled for the next day. So it happens in our setting. It's still happening because we don't have space in terms of operating theater. That's, choosing which patient to go first. And so apart from that, we also have other, our surgical cases as well, like appendicitis case, we'll have to go first compared to, because again, a limitation of operating theater rooms. So it's really, really of impact in our setting.
So, for the interest of time, I'd like to conclude here. Thank you very much for a very interactive lecture and discussion. And I thank speakers Dr. Moss and Dr. Kohia and all the participants. Thank you very much.